great pleasure for me to welcome you all in today's meeting. As you know, we are today going to talk about health crisis, migration, and diaspora in the context of COVID-19. And we have adopted a very interesting format. And I will just, because what we have done is that because of the time lapse, we have recorded presentations from our scholars, and which we will play before you. And then me and another scholar will deal with the question answer session. So I really hope that you enjoy this kind of format, and it will be very interesting for you also. So in this session, as you know, our partners are the Migrant Forum Asia, CCRM, GRFDT, IMAD, and Metropolis Asia Pacific. So we together are going to present before you this session. So first of all, let me introduce our scholars, our panel, which is a very, very renowned and very, very well-known scholars we have today. And the first of the scholars that I would like to present before you is Professor Richard Bedford. He is a geographer. He is an emeritus professor at the University of Waikato and Auckland University of Technology. Richard has been carrying out field work on migration in various Pacific Island countries for more than 50 years. His current research examines the seasonal migration experiences of Pacific Islanders employed in New Zealand's horticulture and viticulture industries. And our second scholar is Professor Vijay Naidu, who is a development studies specialist. He has served at the University of South Pacific in various senior appointments before retiring as a professor and director of development studies and head of the School of Government Development and International Affairs. He has published a range of articles, and he is a very, very well-known name in the Pacific. The third scholar which we have is Dr. Tina Brown Pulu. She is a Tongan anthropologist living in Auckland, New Zealand. She is a senior lecturer in the Faculty of Maori and Indigenous Development of Auckland University of Technology. She writes ethnographic narratives from village life in the Tongan Islands and how Tongan migrants in Auckland keep up connections to their villages and people back home. Our fourth scholar is Dr. Iman Ahmed, who is a global health specialist and a medical doctorate from the University of Khartoum, Sudan. She is basically a Canadian citizen, but she has a wide range of experience on global health and working with United Nations, humanitarian emergencies at various levels. She has also worked with World Health Organization and was involved in the vaccine drive throughout the world. So we have, as you can see, we have very, very interesting panel before you. And so what we are going to do is that, and this particular session, as you know, is about a specific region, the South Pacific, which is a relatively less talked about region, but basically it has a very, very important in the sense of, important sea lanes in the context of very, very valuable marine resources and in several other ways. So we are actually going to talk about Pacific region, which is, and we are going to deal with Tonga, Fiji, and New Zealand, Kiribati. These are the island countries that we will be talking about, but basically the problems that we will be dealing with will be concerning the whole of Pacific Island. So now I think that the video should be played. Dr. Rakesh?
I think the session is recorded. Is the session recorded, Amba?
Yes, sir, it is being recorded.
Just check, double check with Rakesh.
Specific greetings to all of the participants in the online certificate program on the Global Compact for Migration who are attending the webinar on Saturday, the 15th of January, 2022. The theme for this session is health, crisis, migration, and diaspora in the context of COVID-19. At the time you are viewing this short presentation, it is somewhere between 1 and 2 a.m. in Auckland, New Zealand. A map that is centered on Auckland will give you an idea of that part of the globe that we will be referring to in our comments on the theme for this session. As you can see from the map, it is a vast oceanic world within which there are 21 island states and territories, in addition to Australia, New Zealand, and Antarctica, all of which feature prominently in the map. You will hear from 3 presenters in this short video. Firstly, Dr. Tina Brown-Pulu, an ethnographer from Tonga, who is living in Auckland and is part of Tonga's diaspora. Secondly, Professor Vijay Naidu, a development studies specialist who is speaking to you from his home in Fiji. And then thirdly, me, Richard Bedford, a geographer from New Zealand, who is speaking to you from his home in Auckland. Between us, we hope to give you some perspectives on a health crisis, migration, and diaspora in a region where nearly all the countries do not have land borders with their neighbours. We acknowledge with gratitude the assistance of Asim Mukhtar, Auckland University of Technology, in producing this short video.
Tongan stories about migration and diaspora in the context of COVID-19. Fuamotu is dead. Fuamotu International Airport in Tonga was lit up like a Christmas tree for no one. No one was allowed to fly home from New Zealand, apart from the chosen ones whom the Tongan government preordained to travel on Air New Zealand repatriation flights that did not fly often since August 2020. 700 seasonal workers on temporary visas had been left off repatriation flights for 17 months. They felt miffed that others, such as royalty and nobility, politicians and government bureaucrats, business people, even a Mormon missionary carrying Tonga's first case of COVID-19, were priority passengers. Why prioritize people in a safer financial position to take care of themselves? The system of selection made no sense. The anxiety of waiting to go home with no money, no security, made most of this temporary labour force of fruit pickers depressed, while their families at home were worse off than what they would have been if they had stayed in the village and planted taro. My uncles and dad. In 2020, COVID-19 prompted the New Zealand government to shift the country into lockdown for 34 days. In 2021, Auckland was singled out as New Zealand's epicentre of the Delta variant and locked down for 107 days. Boxed up in my 3-metre by 4-metre office at home, I thought about my uncles in Tonga running their villages for the first time under closed borders. Uncle Tui Wakanoa was the former Prime Minister and noble for Nukunuku. He transitioned from being a frequent flyer, Tonga to Auckland to Canberra, to attending funerals and village affairs. Uncle Nuku was the former police minister and noble for Kolonga. He reckoned closed borders was a blessing. Villagers had nowhere to go but the plantation to cultivate crops and the foreshore to forage for fish. Food security was shored up with local produce. My dad was stuck in Auckland. For 2 years he had been barred from returning to his village of birth, his country of origin, the only place he had ever called home. He pored over old photo albums, reminiscing about his early years as a young migrant. Now, at 74 years old, he had done everything he had set out to do and was pining for home. But home didn't want him. The Tongan government would not repatriate citizens over 50. Houses and graveyards. Temporary workers fretted over shipping containers. Some had collected building materials to freight from Auckland to Tonga. But shipping had slowed down to a trickle, whereas cargo costs had escalated. To ship a 20-foot container in pre-COVID times cost 2,800 New Zealand dollars. Now, the same size container cost $4,800 plus $1,200 to clear at Tonga Customs. A total of 6,000 New Zealand dollars. No temporary worker had that extra cash after paying rent and food in New Zealand and remitting money to family in Tonga. No Tongan government would waiver the customs fee. No village houses, battered by cyclones and rainstorms, were getting repaired. The stable social context, not subjected to COVID-19 change, was graveyards. Back in Tonga, villagers continued to emotionally invest in the upkeep of family cemeteries. In the diaspora, migrants remitted cash for family funerals and connected with these events through photos and phone videos posted on Facebook. Houses could be beaten down in extreme weather induced by climate change, but graveyards were a symbol of our permanence, our will to stay on these small coral islands in the world's largest ocean.
From the map of the Pacific that you can see, including the map where Auckland is the center of the world, you can see a vast Pacific Ocean. And because the ocean is so large, in a planet that has 70% water body, the Pacific Ocean area is called the blue planet. The blue planet is our planet, and the Pacific Ocean area is called the blue continent. In this blue continent, which some of our people refer to as our Sea of Islands, we have hundreds of islands. These islands are divided into 3 regions. The regions are called Melanesia, Micronesia, and Polynesia. We have had a long history of migration in this part of the world. Migration has led to diasporas, and diasporas are very important for the small island country peoples because people are dependent on remittances from seasonal workers as well as long-term migrants to what are referred to as Pacific Rim countries, which includes New Zealand. So in terms of people's movement, Micronesia and Polynesia are especially dependent on migration. And there are all sorts of reasons, but there's a fundamental reason, which is that economic opportunities in these small islands with the limited resources are very limited. And so people go abroad to sell their labor and to settle so that they can earn higher incomes and send money home. The COVID-19 pandemic produced this major global health crisis and seriously affected migration. Our region, as some of you would know, is also subjected to extreme weather events with climate change and sea level rise. So as the pandemic spread to the small island states, Cyclone Harold, which was deemed to be a Category 4 and Category 5 cyclone, hit a number of islands in our region. And so people had to cope both with the disaster caused by the cyclone, as well as the encroaching COVID-19 health crisis. So the migrants, who can be categorized as short-term and long-term, were affected. Amongst the short-term migrants were students, seasonal workers, seafarers, and seafarers. The longer term migrants were also affected because the relationships between the diaspora and the home countries is almost constant in terms of people moving back and forth, in terms of remittances being sent, and remittances and in-kind support taking place in a mutual way. So all these were disrupted and caused a lot of problems for people. All small island states, because their health facilities were not of the level that could cope with the pandemic, restricted entry into their borders. So throughout the Pacific, air travel was put to a stop, and border restrictions also applied to ships. So these created problems in the islands in a big way. One of which was that tourism is a big contributor to foreign exchange and earnings in the Pacific Islands. So a number of Pacific Island countries suffered quite drastically, including Fiji, where tourism actually petered out completely, and whole areas and regions were depressed over a period of more than a year because of the loss of income and employment. So these circumstances really affected people. In my case, I do have my family in New Zealand, and our families in Australia and in Canada and in the US. And I find that our links have been really affected because major events like marriages, like funerals, etc., you can't have people traveling. So we have relied very heavily on internet platforms for that. So in respect to the crisis, one very useful aspect was the fact that we have internet these days. Through Viber, FaceTime, Facebook, people have been able to communicate with their relatives abroad and provide, this continuous linkage with family members. And as you will hear, people have been cut off from their families for more than a year, for short-term migrants, as well as for people in the diaspora and the transnational societies that many Pacific Islands have become. And so many of us are waiting very patiently to be able to go and visit our families, including newborn children and grandchildren. And so this is our circumstances. And like the rest of the world, we can't wait till the borders open and we can travel safely to visit close ones. Thank you very much.
I am going to give a presentation briefly on an unexpected consequence of the pandemic. And that is, how do short-term visitors and workers cope when their countries of usual residence close their borders and they can't go home? In January 2022, the government of Kiribati is proposing to open their country's airport on Tarawa Atoll to international arrivals for the first time since March 2020. You can see Tarawa in the center of the map showing the globe. It is right in the center of the Pacific. You can also see something of what the atoll environment is like. For the first time in more than 2 years, seasonal workers from Kiribati who came to New Zealand between October 2019 and March 2020 on contracts for between 6 and 9 months will be able to go home. In addition to the goods that they purchased in New Zealand and the money they saved here while working, some of the women who are returning will take back unexpected children who've been born during their extended stay. What was intended to be a short stay, during which these workers would work long hours picking, packing, and pruning in orchards or vineyards in New Zealand to earn as much money as possible, has ended up being 3 or 4 times longer than expected. So how have they coped? And what lessons can we learn from the way they have coped? Well, first, the easy part. The New Zealand government has extended their visas repeatedly to allow them to stay here legally. So this means they don't become overstayers. Any short-term visitors to New Zealand who were trapped by border closures and were unable to return home have had their visas extended. But visa extensions don't pay rent or put food on the table. How have the seasonal workers and the employers who recruited them and who are legally responsible for them while they are in New Zealand, how have they coped? Seasonal work, by definition, is confined to specific periods of high labour demand for harvesting crops, packing produce, and pruning trees or vines. It is not continuous work throughout the year. These seasonal workers who come are experts at working with particular crops for specific employers. But because of border closures, they have had to learn new skills to pick, pack, and prune different crops for different employers. They've had to do this to be able to earn money to pay for their accommodation and food, and to earn enough money to send home to the families in their islands who are depending for their lives on the remittances that the workers earn. The New Zealand government has helped at certain times by providing employers with financial assistance to pay accommodation and food costs for workers when they have not been able to get work. In New Zealand, there has been a policy of wage subsidies provided by government to all employers whose employees have not been able to work because of the pandemic. But this support, while welcome, has not been enough to cover all the costs of living in New Zealand. The diaspora communities living in New Zealand from the islands, they have provided considerable support, both for the visitors trapped in New Zealand and for families back in the islands who've not been able to send workers to New Zealand because of border closures. Non-government organisations like the Red Cross, churches, and community welfare agencies have played a major role in helping workers at times of significant emotional stress, such as when they get pregnant and have to have a baby in New Zealand. The compulsory medical insurance that seasonal workers they have to have in New Zealand doesn't cover the costs of childbirth. After all, these workers are not supposed to be here long enough to have babies. What the pandemic has revealed across the region and in many other parts of the world is that a health crisis that leads to countries everywhere restricting the return of their citizens who are overseas on temporary work or study or visitors visas requires more than just extension of visas. An essential component of support for migrants who cannot get back to their home countries is a comprehensive package of humanitarian assistance. In many countries, including New Zealand, the humanitarian assistance provided to short-term visitors trapped by the COVID-19 pandemic did not begin for several months. With hindsight, the response was too slow. There have been many lessons learned during the current pandemic, and a key one relevant for immigration policy is that humanitarian assistance for those without work and with only short-term work who are unable to return home needs to be available quickly. Being unable to return home because of border closures was unexpected in 2020. In 2022 and beyond, it should be an anticipated consequence of any future global pandemic like COVID-19. Finally, a recent report on coping with disaster in the Pacific region explores how there could be more regional harmonization of approaches to humanitarian entry and stay in the Pacific. Thank you. We hope these brief comments from Tina, Vijay, and me have given you some insights into how a health crisis has impacted on migration in a region of island countries. The long-term implications of the pandemic for migration policy in the region are still unclear. But one thing is certain. We have been given some valuable insights into the need for much more coordinated humanitarian responses to crises that affect entire regions and indeed the entire globe. These are useful lessons for how we will need to cope with climate change longer term. Thank you.
Thank you, Dr. Rakesh, for playing this video. I hope all the participants thoroughly enjoyed this beautifully made video. And maybe very short comments, but you got a very deep insight into what exactly is happening in the regions like Pacific during this COVID. So now what I will try to do is to briefly present some of the highlights that I thought is important to note in this discussion, and then we can proceed further. So as we can see that this session concerns with the South Pacific region, and this region is a vast oceanic area with 70% water, and also known as the Blue Continent, as Professor Naidu said. So the countries do not have land borders with the neighbors. This is a very, very specific condition. Also, we have seen that how countries which have land borders with the neighbors faced COVID during COVID situation, because it was very difficult to stop this migration through porous borders. But see, the countries which do not share borders also have a very specific set of problems, which was highlighted in these three presentations. So the first presentation was actually about Tonga, and the presenter, the scholar, Dr. Tina, said that actually in such countries where the only contact with the outside world is through air or sea route, and that was stopped. And in that case, this country was completely cut off from the rest of the world. And there were some repatriation flights from New Zealand, but as the presenter said, it was based on the priority basis for VIPs. Actually, the VIP passengers who were actually those who could have afforded living in New Zealand, but they were given priority instead of the common passengers who were left with no money because their period was short term. They went there for a short term period, and that is why they were unable to feed themselves. And also because of this, all the work stopped. There was just no way these short term migrants could earn. So, and one of the other things that she pointed out was that since the travel became very expensive, it was very difficult to send the goods also to these countries. And I don't know how much you are aware, but these island countries depend too much on these Australia, New Zealand, and other developed countries for their daily life. For example, even during supposing during a typhoon, the house is destroyed, then they need material from New Zealand to repair those houses. So in this situation where everything was stopped or became very expensive, it was impossible for them to carry on their lives. The second presentation was by Professor Naidu. So he talked about the Fiji or the overall Pacific region, and where he said that there are three ethnicities, Polynesia, Melanesia, and Micronesia. And this region is, it is prone to natural disasters. So since the economic opportunities are very low, the people migrate and send remittances. So during this time, and because the health facilities are very marginal in these island countries, there was no way other than stopping the complete contact with the outside world to stop the spread of the disease. So once everything stopped, the remittances stopped coming in. So it was a major loss for the islanders. And since the travel stopped, the tourism completely stopped. Tourism is another, a major source for these island countries for revenue. So tourism also stopped. And in this condition, the two major sources of income that these island countries have, remittances and tourism, it completely stopped, and which led to a great difficulty for the islanders. And of course, cutting off from the family and the loved ones who were settled in different areas of the world, that was also a very, very emotionally difficult time for these islanders. In the third presentation, Professor Bedford talked about the Kiribati, the migrants from Kiribati in New Zealand, and he brought out very interesting aspects that these are seasonal workers who go to New Zealand to earn for very short time. They got stuck there. So, and New Zealand government extended the visa, but other things, the food and the accommodation, everything had to be taken care of. To some extent, New Zealand government covered. To some extent, the Kiribati diaspora who are settled and well off in New Zealand, they also helped, but it was a very, very nominal thing. And it was very difficult time for the migrants to face this situation, and several health issues, because they are not covered in the health insurance scheme of New Zealand. It was very difficult to cover them and give them medical assistance in the times of need, like Professor Bedford mentioned about women. So what happens is that there is a huge emotional stress that these short-term migrants faced in wherever they were trapped. And to think about a very, very coordinated policy to address the trapped migrants in such situations is very important. So to conclude, we can see that in case of such health crisis at global level, where the workers are trapped and cannot go back, a comprehensive package of humanitarian assistance is required, and this should also come in a timely manner and in a regionally harmonized fashion, because especially in the regions like South Pacific. So that's what Professor Bedford concluded. So I will stop here, and I will invite Dr. Iman to give her presentation. Dr. Iman.
Thank you very much. Good morning, good afternoon, and good evening to you all. I hope you can hear my voice. I'm delighted to be with you today, and I thank the RFDT for inviting me to contribute to this session. I will bring more of a global health overview to this session, and it's very interesting to see a kind of a more focused view from the previous presenters. I'm also pleased to be with you today. So I have prepared a PowerPoint presentation that I will be sharing with you right now. Please let me know if you can see it well.
I think some other things are coming, not presentation.
Is it on now?
No, it is on, but you open the PowerPoint.
Sorry.
Please open your PowerPoint. This is coming some email, I think.
Pardon?
No, you have PowerPoint presentation, no?
Yes.
You open first that PowerPoint, then you can share.
I'm sorry.
Yes, first you open that PowerPoint, then you can share.
Yeah, I have it on.
Then you do screen share. Yes. Yes, coming.
All right, thank you very much. I'm sorry about that. So my name is Iman Ahmed. I'm from Canada. I grew up in the Sudan, so I'm a migrant myself. And my journey spans a number of countries of the world for both living there and working. I've been working in global health throughout my career. My presentation also falls in the domain of health, crisis, migration, and diaspora. And the outline of my presentation is that first I will give some background about the concept of universal health coverage, which is a basic concept by the World Health Organization. I will speak a little about the intersectionality of migration and health, as well as the intersectionality of the determinants of migrants' health. I will then talk about, I'll bring some case studies or highlights about various cases from different countries, showing the impact of the COVID-19 pandemic on migrants. I will highlight the case of Saudi Arabia, Singapore, Canada, and finally the United Kingdom. And the case of the United Kingdom has a short video also that I will be showing. And then after that, I will also talk about the international health regulations, which is an international law instrument and governing actually issues of global outbreaks, the spread of disease, and the various public health aspects of that, and how it intertwines with issues of movement. I will also bring some highlights about the COVID-19 vaccine equity issues, because this is a major global health concern these days, and then open up for discussion and reflections on the way forward. What can we do after that? So what is the international health regulations, basically? The concept of universal health coverage is defined as having all individuals and communities receive the health services they need without suffering financial hardship. And it includes the full spectrum of essential quality health services, starting from health promotion all the way through prevention, treatment, rehabilitation, and palliative care across the life course. So it's important to note that it's quality health services, and it's not just access to the bare minimum. Universal health coverage was adopted by the WHO and by the world nations under the Sustainable Development Goals in 2015. And then further on reaffirmed at the United Nations General Assembly high-level meeting specifically dedicated to universal health coverage, and that was in 2019. It's also one of the WHO 3 billions or 3.1 billions target for 2025. And the 3.1 billions target basically rests upon the fact that there are three major goals of 1 billion more people benefiting from universal health coverage. That's on a global scale. 1 billion more people better protected from health emergencies, and 1 billion more people enjoying better health and well-being overall. it's also part of the WHO's mission on the right to health, and as well, the right to health involves the highest attainable standards of health. Again, not a bare minimum. Also the concept of health for all and the sustainable development goals. Okay, this slide shows the intersectionality of health and migration. If you see these four blocks, we have health, migration, human rights, and gender. That's how I thought I should put it up. When we talk about migrants' health, we cannot ignore migrants' human rights. And in some cases, there are gender-specific situations, there are gender-specific issues that come up. So a female migrant worker suffering from certain health issues, but if you try to view it through the gender angle, you cannot ignore the human rights angle, the migration aspect, and the health aspect. And that is why whenever we talk about migration and health, we need to center and position our talk into this intersectionality. Another scheme of intersectionality is that of the determinants of migrants' health, where there are structural determinants of health, and these include the systems that provide health or exclude migrants from health, from receiving health. And not only that, not only migrants, but migrants and diaspora members, as we will see in one of the examples, notably the UK example, as we speak. There are the socio-cultural elements as well of the migrants' health. For example, if we have a migrant community living in a specific area, there's the environmental aspect and the economic. For example, migrants living under, let's say, poor socioeconomic conditions, they are excluded from access to certain jobs or the higher ranking jobs in the society. This is impacting their living spaces, the environment where they exist. And there are socio-cultural dimensions where, for example, you live under poverty, but you still have to save money to send back home. Again, all of these determinants are intertwined. And sometimes the four elements keep people into circles of poverty, perpetual poverty. So I wanted to bring that in to open the discussion before we see the examples. Now, I would like to show some global evidence on the impact of COVID-19 pandemic on migrants. There is a policy brief issued by the OECD recently, which is the Organization for Economic Cooperation and Development. And the policy brief is titled, What is the Impact of the COVID-19 Pandemic on Immigrants and Their Children? The major finding of this multi-country study was that, I'm just quoting it here, due to a range of vulnerabilities, such as higher incidence of poverty, overcrowded housing conditions, and high concentration in jobs where physical distancing is difficult, immigrants are at a much higher risk of COVID-19 infection than the native-born communities. Studies in a number of OECD countries found an infection risk that is at least twice as high as that of the native-born. So in the first year of the pandemic in 2020, we were saying, okay, we don't have enough data. We don't have enough data and not enough evidence to show if this is impacting migrants and diaspora more than other native-born communities, but now the evidence is out and we need to look at it with, it's really an eye-opener. All the evidence that's out has put the world in confrontation with its own moral values, with its obligations towards issues of equity, inclusion, and so on. Other findings of the multi-country study include revelations on job vulnerability. For example, migrants are always at the forefront of high-risk jobs. They sometimes don't have sufficient health insurance, as mentioned by the esteemed speakers in the previous presentations. Even the school closures, now people are going through this in different countries of the world where children have to stay at home and study online or remotely. School closures are affecting migrant families more than other families, where the two parents, for example, are having to work to earn money to send money back home, and babysitting is difficult, but they still have to spend time with the children. That means perhaps one of the parents has to stay at home, abandon their job. This will impact the income level of the family and the living conditions, the money that is being sent back home, and so on. Another finding is also higher COVID-19 mortality. So it's not only morbidity and the numbers of cases among migrants, of course, it's coupled with higher death rates. Okay, further on this, I'm bringing in some statistics from the OECD study. Pardon? Okay, this. Hello? Incidence data on confirmed cases of COVID-19 among migrants versus all the population, or the entire population. In Norway, the incidence among foreign-born nationals or residents was found to be 31%, whereas in the general population, the incidence was nearly half of that. In Sweden, the incidence is 32% among migrants versus 19% in the population. That was during the period March to May of last year. In Denmark, 18% of migrants and their native-born children, that's the incidence among migrants, including their native-born children. So even if you are a native-born child of a migrant, they are still more impacted than the rest of the Danish population. And that was twice as high as the rest of the population. In Portugal, it's 24% in Lisbon area. That is 24% are migrants, and they are mainly from Africa. The incidence is 24%. Sorry, yeah, 24% among migrants, I'm sorry, but they represent around 11% of the total population. So this is a different type of statistics where the migrants' share of the population is 11%, but their share of COVID-19 infections is 24% of the total. That means a quarter of the infections in Lisbon area is happening among migrants. And finally, in Canada, Ontario, permanent immigrants accounted for 43.5% of the cases, but their share of the population is only 25% of the population. That is nearly they're shouldering nearly half of the number of infections. Okay, now these are a few case studies, as I mentioned. This is starting with Saudi Arabia. And this is a tweet by the Ministry of Health on the 7th of May, 2020. I think it's a positive. It's important to highlight that it's a positive practice. It's good practice that Saudi Arabia disaggregated the data from the beginning by nationals and migrants, because this was lacking in other parts of the world. And it required a lot of advocacy to demand disaggregation of data and show the impact of COVID among migrants, among people of color, among people of other ethnic origins, and the diaspora communities. And we will be able to see that also in the UK case. So 75% of all newly confirmed cases as of May 2020 were among migrants. So Saudi nationals, the infection rate was 25%, while non-nationals, 75%. The second case study is from Singapore. Again, in Singapore, over 90%, 95% of the confirmed cases by June 2020 were among migrants. And within that, Singapore has what's called the migrants' dormitories. And I'm showing a picture here of a migrant dormitory. And you can see how overcrowded the people over here are, which goes against, of course, infection prevention and control, community prevention for COVID-19 and for all airborne or aerosol-generated infections. Now in Singapore, as I mentioned, 95% and more of the cases were among migrants, and within this, out of the total, over 93% of the cases were related to these migrant dormitories. The third case study is from my own home country, Canada. And this picture to the right is of the Cargill meat packing plant in Alberta, Canada. In the summer of 2020, the plant had to shut down briefly because of a COVID-19 outbreak among its mostly Filipino workers. This is one of the sites that is known for hosting migrant workers. And I think the picture is very clear here. This picture was shared with the Canadian news channel CBC in 2020. And you can see how crowded it is over here, and the same story as the dormitories in Singapore. And it's also important to say that this outbreak in the summer of 2020 was not the only outbreak. The meat plant experienced other outbreaks, as well as lots of strikes, negotiations between the workers and the employers. The story has been going on for quite a long time in Canada, and it had its ramifications. Now, further on Canada, there's also the story of the migrant agricultural workers. This excerpt is from a report of the Auditor General of Canada to the Parliament as part of the independent reports presented. And the title of this report is Health and Safety of Agricultural Temporary Foreign Workers in Canada during the COVID-19 pandemic. As in the case of New Zealand presented by Professor Richard a few minutes ago, Canada depends heavily on migrant workers, whether in the meat industry, in agriculture, or other sectors, even in the health sector. The findings of the report basically audited how well the funding from the federal government that was provided to the office that regulates the employment of migrant workers, their conditions, and so on, through private employers, how well that funding was channeled. So this is a multi-layered process. Funding went from federal government to Employment and Social Development Canada, which regulates employment of temporary foreign workers through what's called the Temporary Foreign Worker Program. And these foreign workers are employed by private investors to work in the types of industries that I have just mentioned. The finding says, overall, we found that Employment and Social Development Canada's inspections under its Temporary Foreign Worker Program provided little assurance of protection of the health and safety of temporary foreign workers in Canada's agricultural sector during the 2020 and 2022 growing seasons. This is the main finding of the report. And the finding basically pardon me, the report audited the health inspections, inspection visits, inspection acts, and compliance of the employers with the requirements. And there were lots of issues in terms of the overcrowded housing of foreign workers, living conditions, delays in receiving their wages, access to health insurance, visa expirations and needing help with visa extensions and staying in limbo for certain periods, a range of issues. So if you see, this is also comparable to what's happened in other parts of the world, as mentioned in the case of New Zealand. The last case I'm bringing is from the United Kingdom. The picture you see is a very unfortunate picture of all the doctors who lost their lives at the forefront of the COVID-19 pandemic in the UK. If you just have a look at the diverse backgrounds they show in this picture, 95% of the doctors who've died from COVID-19 in the UK were people of color, mostly from migrant backgrounds. Now, I'm just bringing a very interesting interview by the BBC's David Harewood, and he interviewed Dr. Godi Singh, a pediatrician and expert in health inequality issues. So I'll try to play the video, and I hope. All right.
Sorry, is it just me? I cannot hear anything.
None of us can hear anything. Yeah.
I think the volume should be adjusted. Imam?
I'm sorry, were you not hearing the video? Hello?
No, the sound was not coming.
I'm sorry about that. I hope you were able to read the text. So basically the main thesis of this video. Yeah, I'm sorry about that. The main thesis is that she speaks, the doctor herself of migrant background, and she speaks about the fact that 95% of the doctors who died from COVID-19, as I mentioned, were of migrant backgrounds, how one of the reasons was that these people are working in frontline roles versus the management roles held by people of non-migrant backgrounds. The fact that they didn't feel confident enough to demand or better working conditions in terms of availability of personal protective equipment, and they didn't think their voices would be heard, even if they mentioned that. Okay, so I'll leave it to you to reflect on these 4 cases that I have presented, and we'll wrap up the discussion with just a small part on the international health regulations, bringing it back to the global health regulations and international law. The IHR 2005 was adopted by the Health Assembly in 1969, having been preceded by a previous regulation called the International Sanitary Regulations, and that was adopted much earlier in 1951. Initially, the international health regulations covered specific diseases, 6 diseases, which were called quarantinable diseases. And then it was amended in 1973, and after that, 1981. The mainstay of the regulations is primarily to regulate or to provide public health advice and guidance on the spread of diseases. So as it evolved, and after the severe acute respiratory syndrome that affected the world in the 2003 pandemic, the disease specification was removed, and the IHR was adopted as an instrument of international law in 2005 by the 58th World Health Assembly. And then it entered into force on the 15th of June, 2007. So this is an image of the booklet of the International Health Regulations. What I want to say here is a very important thing, that this is an 84-page booklet. Nowhere in this book does the WHO, the world nations actually, who agreed and signed and ratified this instrument, nowhere does it talk about border closures. Nowhere does it advise border closures. On the contrary, the main purpose and scope of the IHR is to prevent, protect against, control, and provide a public health response to the international spread of diseases, as I mentioned, in ways that are commensurate with and restricted to public health risks, and which avoid, and this is a very important part of the statement, which avoid unnecessary interference with international traffic and trade. So traffic, it's movement of persons and trade. What we see these days under the COVID-19 pandemic goes completely contrary to the purpose and the spirit of the international health regulations. It advises nations about specific public health measures, training of personnel, and as part of the IHR, richer countries are also, they have an obligation and they are expected to support less fortunate countries in improving their health systems to be able to deal with disease outbreaks on the global scale. So we need to stop and ask ourselves, why are border closures happening and how they are impacting migrants? Border closures are national decisions. The decision to close borders are mostly national. And I think we have seen a very vivid example of the recent Omicron virus and how some European countries and North American countries rushed to ban flights from South Africa, where the virus was detected by the scientists, but there was no evidence that it started there. And then later on, some stories emerged that it has existed in France and in other European countries even before it was discovered in South Africa, which has a robust science. So these are all issues for us to reflect upon as we look at COVID-19, migration, and the intersection of health and migration. Now, lastly, I would like to close my presentation with a bit about COVID-19 vaccine equity. On the global scale, as of yesterday, there have been more than 318 million confirmed cases of COVID-19, which include around 5.5 deaths around the world, reported to WHO. There are lots of deaths, of course, unreported. And on the other side, when we talk vaccines, a total of more than 9.2 billion vaccine doses have been administered in the world. So that being said, let's look at the image below, which shows the distribution of vaccines around the world. To the left, 67.6% in the high-income countries of the population in high-income countries have received at least one single dose of vaccine. And in low-income countries, the rate is 11.36% of people who have received at least one dose. So how does this link to migration? Number one, some of the richer countries did not go straight to guarantee vaccination to all people within their borders. It took decision-making. And I feel proud and I feel assured that Canada, this was one of the earlier decisions that came through, that vaccines are guaranteed to everybody, regardless of their migration status. Some countries in the Gulf, countries in Europe. So this is an example of good practice, that countries proactively guaranteed vaccination to everybody. The second point, even though this is the case, not everybody felt confident. People who are undocumented migrants have experienced hesitancy, and I had the chance to work at the forefront of a vaccine, managing a vaccine clinic during 2021. And I remember, I'm going to bring an anecdote here. I remember somebody coming with their mom to the vaccine clinic. They came very hesitant. They were unsure whether they will be served or not. And the first thing they mentioned is, the person mentioned is, I'm bringing my mother. She does not have any papers. What we required at the clinic is personal identification, just to make sure that the person who is here is the person whom they say they are, and for documentation purposes. So after having a short discussion with this person, it turns out that the mother is an asylum seeker. She does have some refugee claimant document, but they did not feel that this is good enough. There was some element of shame, if I may say, in bringing up this fact. It took some assurance, taking this family to just like to talk to them in private, give them the assurance that they are going to receive vaccination regardless of their migration status. And then after that, they immediately, they lived close by, turns out. They went and brought the documentation. And then I happened to see the same family for their second dose, but the second time they didn't need to, they just like came very smoothly and automatically. I think for me, this was an example of good practice, of bringing policy down to practice, because the government policy existed. At the clinic level, we as clinic workers were informed, and we had the correct messaging to deliver to the public. It also highlights the need to publicize when government policies are put in place. They need to be publicized widely for categories like the migrants in the example I gave. So finally, to close with, I would like to quote Dr. Tedros Adhanom, the Director General of WHO, who has been saying from the beginning of this pandemic that no one is safe from COVID-19 until we are all safe. This applies to nationals, migrants, and people around the world. And as well as Dr. Maria van Kerkhoff, who was talking to us at a webinar recently, and she said, we cannot vaccinate our way out of this pandemic. So richer countries cannot think that they can close their borders and continue to vaccinate their people to end the pandemic. This would not end the pandemic. We are in this together, as we say, and this is the only way is to be more inclusive, and that includes migrants, diaspora, and nationals, people who are living under poverty, as compared to those with higher living conditions. So what's the way forward after all of this? There were examples that I just touched upon very lightly. The case of the Kargil meatpacking, there was strong advocacy, as I mentioned, around the rights of migrant workers. And I think around the world, we have seen some solid examples of advocacy for migrant workers to have better working conditions, to have access to healthcare, to have access to insurance, and so on. So advocacy continues to be a very important cornerstone in improving the conditions for migrants and diaspora. As well, we need to start compiling best practices from around the world and share them. And we need to think globally and act locally. So thinking globally, I think this evidence is strong enough to prompt us to approach the matter in a more global manner. But in the end, every one of us we have a duty to act locally within our communities, within our workplaces. If we see inequity, we need to speak up. If we see discrimination against migrants, if we see vulnerable conditions for migrant workers and so on, we need to join hands and speak about that. And finally, avoid the silos, work together, and adopt a systems thinking approach. In the case of the UK, there are structural issues impacting the system. These issues cannot be addressed in silos. We need to think of the economic, the health, the migration elements and bring them together, and finally adopt a rights-based approach when we tackle all of these issues. And finally, this is a beautiful image from the WHO that says no one is safe until we're all safe. Thank you very much. I hope I didn't go too long. Thanks.
Thank you very much, Dr. Iman Ahmed. Thank you indeed. And this was a very interesting and in a way eye-opening presentation. And I'm very sure that all the participants would agree with me for this, your own first-hand experience that actually enriches your knowledge so much that, you can just connect with the audience with such a great zeal. Thank you very much. Thank you. Thanks a lot. And this was really a great session, I would say. And we came to know so many aspects of so many, case studies we came to know. So now I will invite questions. We will try to answer. Dr. Iman and me together would try to answer your questions. Can you please raise your hand? I can then so here we have, just a minute. We have one question from Joan Gloria. Would you like to ask or should I read it? Joan? Well, yes.
Okay, hello.
Hello. Please
So
go ahead and ask your question.
Okay, I was not sure because I'm not in a very stable place, but if you can hear me, then I can go ahead. Okay, thank you very much, our presenter. Thank you, our moderator today. The topic is really very relevant today in the world of work and the issue of COVID-19. My question or my concern is that I want to believe or think that the issue of COVID-19 is not about or lower the rates of migrant workers or migration workers, such that the migrant workers would be required to be vaccinated before they migrate for work, as it is needed by the destination countries, and yet some of them are fearful of this vaccine. Now, how do we then convince them that they are safe? And yet we have said nobody is safe until they are all safe. And again, if for the sake of those undocumented migrant workers, how then do we support them when we require them to come forth for vaccination for the case of prevention or protection? How then do we tackle that kind of issue? Thank you very much.
Dr. Amber, you are muted. Dr. Pandy, you are muted, sorry.
Okay, so what I'll do is I'll just quickly read the question because the voice was not clear. So this is a very relevant topic, but I just have one concern that the issue of vaccination was hindered or lowered the rates of migration because of the need or requirements by destination countries to have people getting into their countries be vaccinated, and yet many are fearful of the vaccine. And another issue is could the migrant workers be discriminated from being vaccinated? What then should we do as the GCM to counter such things? So this was the question.
So I can tackle this issue. It's quite interesting that, as I said, vaccines are not distributed equitably around the world, yet still movement is now restricted to having completed your vaccination. So in the first place, globally, we are not distributing vaccines equitably. Less vaccines are going to lower income countries that are the same countries sending migrant workers. Yet still they have to be fully vaccinated in order to enter. And I think we will see the ramifications and the result of this. We will be seeing it in this year and next year's movement of persons. That alone, talking about access to the vaccines, leaving aside the issue of vaccine hesitancy and what all the governments did or didn't do in promoting the vaccine itself, because this, again, of course, there is the issue of misinformation, disinformation, which the WHO calls the infodemic, and is doing a lot of effort to manage the infodemic. And this is a good example. Your question highlights the need to act in a very integrated way to tackle these issues in a collective manner. So what we can do under the GCM is not only to advocate at the small scale, but tackle these issues, as I said, in their reality of intersectionality, of the complex nature of it, and then to advocate and influence policy. Because I think at the level of the GCM, we can do more than just advocate. We can also influence global policy. Thank you. I hope I have answered your question.
Okay. So are you happy, Joanne, with the answer? Well, okay. So the next question is by Jacob Weiswa. Would you like to ask yourself, Jacob? Well, I'll just quickly read the question, but we have different local conditions around the world when talking about COVID-19. In many parts of the world, it is like a ghost. Thinking local and acting global is best and most sustainable instead. So he thinks that thinking global and acting local instead, we should think local and act global.
Why not? I really appreciate that you flipped my my suggestion and my statement, and I find it very rational and absolutely. And sometimes in the place where we exist, the best thing for us is to think locally, and then the collective of our actions would definitely be acting globally and influencing global policies, global actions. Thank you very much for that, Jacob.
Okay, but I think, let me add one thing here, that the countries who are actually holding the vaccines and thinking that, in a cocoon, they can survive by, protecting themselves, they are actually thinking local. So think about this one partially, if they think global, then they will realize that unless and until, like, the statement, the quote, which Dr. Iman said in the evening, that in the end, that unless and until everyone is safe, no one is safe, so that also is one of the angles to it.
And thank you, Dr. Pandey. If I'm allowed to add also, this is something I missed in the presentation, but according to Gavi, the Vaccine Alliance, the countries of the world, the richer countries are wasting more vaccine, by the way, more of the COVID-19 vaccines than the wastage happening in poorer countries. Wastage in poorer countries amounts to around 0.02% of the vaccine doses. That is around like 300,000 something doses. But at the same time, very recent statistics showed that in the UK alone, around 800,000 doses of AstraZeneca was going to expire when the country changed its policies. So this is very nationalistic thinking.
Yes.
And now the vaccine has gone to wastage. So another example to add to the whole picture. Thank you.
Yeah, the global thinking, unless and until you do that, then we are just concerned with our country, our region, place. Anything else?
Hello.
Yes.
This is from Sheku Bangura.
Please ask, yes.
My question is going like this. How best can these people try to expedite the process of getting vaccines of the other countries that are not fortunate, right? So how best they can expedite so that they can get their vaccine as soon as possible? Because, everything now is centered to the vaccines. Each and everything now, programs, all other programs centered to vaccine, you must be vaccinated. So you can see a lot of young people losing conferences, losing some other things based on these vaccines, right? So not that some of them, they don't want to be vaccinated, but just because the vaccines is not available to their countries. So how best can they expedite the process so that these people will be fortunate, so that they can enroll to conferences and other programs that require vaccinated card? Right, that is one. The other one, again, the presentation is so nice, very much interesting. Just because we put on the videos on, we are not able to access to the entire presentation, only half of it that we got with. So now, will it be possible so that you can see this presentation to our mails or wherever we can get the presentation? This statistic is so nice and so accurate. So we would like to get that statistic if that's possible. We'd like to get the presentation, the documents, if that's possible. This is the second one. Finally, let me just wait for the response first before I hit into the other question. Thank you very much.
Sure. Thank you, Dr. Pandey. May I go ahead?
Please do, yeah.
Thank you. So thank you very much for your comment, and I appreciate your reflections on the presentation. The presentation will definitely be shared in the classroom. I will also add the IHR document to it, and I have made sure to link all the sources that I quoted in the presentation. So even the video about the UK is a YouTube video available on YouTube. It's a BBC video, but it's available, and all of the other case studies are linked there, all of the sources of information, whether it's Gavi, WHO, and so on. I will also add this bit about the vaccine expiry to the presentation before sharing it with you. And I'll be happy to send it to you by email as well. Thank you very much.
Okay.
It's not fully answered. It's not fully answered. There's a caption left behind, and so interesting about that cap. The other country that not get fully the vaccines. This vaccine has become a requirement to any other process, right? So on that sense, according to our presentation, say, oh, there are other countries that they don't even give much vaccines, and those other countries that left behind that won't get the vaccine. How best they can expedite this process so that this country will be fortunate to get the vaccine and able to enroll to all other activities that require vaccinated card. Because all other programs now center to vaccines. If you are to attend hybrid programs, they require that. That one is a requirement now. You should have it because you are going to mingle with a lot of other people. So they make it as a requirement to all other conferences, all other programs that has to be in person or hybrid programs. So in that note, that is why I ask kindly how best they can be able to expedite the program of the left out country. This is my question. I need a clarification on this.
Dr. Iman, would you like to address, as most of the questions are concerned with your presentation? So,
all right, sure. I think what you're asking is, if I heard you correctly, is about the vaccine distribution around the world. And all I can say is that the WHO has devised this COVAX mechanism and the ACT Accelerator, which was created specifically to ensure the flow of vaccines to all the countries of the world. This is managed through the national ministries of health. They are responsible for the procurement and distribution of the vaccine, supported by the WHO COVAX, which involves the Gavi, the Vaccine Alliance, Global Alliance for Vaccines. And so this is the global mechanism for procuring COVID vaccine. WHO did this specifically to make sure that to lessen and minimize vaccine hoarding, vaccine inequity, or bilateral deals. But bilateral deals are still happening between manufacturing countries and the companies manufacturing them and the richer countries of the world. So this is a very, I think you tackled the core of the problem of vaccine equity. All we can do is to ensure the national ministries of health do their best to procure and distribute vaccine. Once it's there, it's our duty also to step forward and make sure to receive our doses. It's our duty. It's also upon us as members of the community to promote vaccine. I am a Canadian citizen who's of Sudanese origin, and sitting now in Toronto right now, I am participating, doing just my little part towards my home country, Sudan, where we are promoting vaccine around the villages. We have teamed up with medical students. I'll just allow myself to bring this in. I'm part of the Sudan Doctors Union in Canada, and we are teaming up with other organizations of Sudanese diaspora around the world. We have an initiative around COVID-19 awareness and vaccines, because the Ministry of Health did bring some vaccines through the mechanisms I have explained. But getting the vaccines into arms, jabs into arms, as as our Prime Minister of Canada has been saying. Getting the doses to the people is yet another tier of the distribution, the supply chain. And that's where acting locally is very important. So thinking globally, we think of vaccine equity, how the vaccines can reach the countries. Acting locally is how to get the jobs into arms by promoting vaccines, by inviting public-private partnerships, the private sector, engaging them to support with their supply chains, to distribute the vaccines to the remote areas, engaging all of the energies of younger people who are dynamic enough, who can convince their grandmothers or their youth peers and so on to promote the vaccine. These are just examples. And I hope it answers. I don't have a magic wand to answer all of these very important issues, very vivid challenges around the world. So thank you for bringing them up. And I'm sharing just my example from my home country, Sudan.
Thank you very much. Actually, this was a very, this answer covered a lot of several issues, and the next question also, which says about how we can motivate the citizens to get vaccinated, that is also partially answered in this answer. So I think now we are done with, and we are short of time. So I would like to close the session, and in the end, I would like to invite Dr. Paddy to come and give the vote of thanks.
Dr. Ambapande, thank you. I always say it's very infectious to be around professors and doctors, so you end up being called Dr. Paddy. And I hope you're speaking into the future there as the influence that I am getting around
yes.
speakers that I am proud to associate with through GRFDT. And thank you again, Dr. Ambapande, for a fantastic moderation, facilitation, and engaging us in this particular topic. To Dr. Iman Ahmed, thank you so much for giving of your time, of your knowledge and your experience. I think we have really been enriched. And a special thanks also goes out to, and I think it's important for us to point this out, the collaboration that we have. If you see the logos that we have on our posters, we just don't put them there for the sake of putting them, but there is actually a big collaboration. And today we were able to see the Metropolis Asia Pacific, particularly the steering committee members joining us today via video because they are fast asleep. And so we are kind of glad that they could find time not just to put the video together with inputs, but a very interesting reflection, very personal reflection as well that has come. So special thanks to Professor Richard Bedford, Professor Vijay Naidu, Professor Tena Brown-Tulu, and also special thanks to Asim Mukhtar, who was working with Professor Brown-Tulu and produced that fantastic video. So he's a film producer. And actually we will share both this recording, but we will also be sharing the direct YouTube link that was played today, which will only be airing today. So we will be sharing that. So special thanks to Metropolis Asia Pacific for this great collaboration. And also special thanks again to Dr. Ambapande for taking on the reflections. One last announcement before we move. We are back full swing with the GCM webinars. So we ask you to please book in your calendars. Next week, Tuesday, the 18th of January, we will be combining two Global Compact for Migration objectives, objectives 11 and 12, that look at procedures, but that is also looking at management of borders. And we feel the two are combined, but we're also just trying to catch up with the bulk of webinars that we have on hand before we finish the session. So please join us. Be reminded that the time is 3 p.m. CET. So 3 p.m. CET, Tuesday, and then again we have the session on Saturday, and the full agenda has been shared in the Google Classroom. We really ask you to download that, take note in your agendas, and in your calendars so that you do not miss any of the important events. And for those who are just joining us because you're friends of GRFDT, friends of Metropolis Asia Pacific, friends of MFA, CSAN, and all the others that join us as partners for this course and also for other courses as well, we say thank you and have a wonderful, safe and healthy Saturday. Thank you, goodbye.
Thank you. Goodbye.
Thank you very much. Thank you very much.
Bye.